Now you can start your presentation. Thank you.
Okay, thank you so much for that wonderful introduction. First of all, I would like to thank the İzmir Neurosurgery Society for giving me this honor to present my talk in front of such an esteemed people and esteemed audience. Thank you, Dr. Hassan, for giving me this opportunity. I met you in February in Turkey for the endoscopy conference, and I always enjoy my time in Turkey. I have lots of friends in Turkey who are eminent surgeons in spine, in orthopedics, as well as neurosurgery, and I know they all are doing really very great job. So, with that, I would like to start my talk today. I would be speaking on uniportal endoscopy approaches to lumbar stenosis. Now, we all know that acquired stenosis of degenerative type is due to actually the changes in the three joint complex, which consists of the intervertebral disc, the associated superior and inferior vertebral bodies, and the facet joints. And generally, degeneration can start in any one of these three, but eventually involves all the three structures. So if you see the schematics, it could be starting with facet degeneration. It progresses to synovitis stage, and then there is facet capsule loosening. This increases micromotion and mobility at the segment, and which creates excess stress on the intervertebral disc, and there is accelerated disc degeneration. Finally, our body, it tries to stabilize that segment by forming osteophytes. There is ligament flavum hypertrophy, even mineralization, calcification of that ligament flavum, and facet hypertrophy. Now, traditional spine surgery for lumbar spine, as we all know, whether it is lumbar discectomy or stenosis decompressions, these are extensive surgeries. These were large exposure surgeries where we used to cut the bones, we used to cut the spinous process, we used to cut the interspinous ligaments, we used to scrape and elevate the muscles from the lamina. And then we used to do laminectomy and facetectomy to gain approach to the spinal canal. Now, this was actually a very challenging approach for a very small pathology in a great depth. So, from the skin of lumbar spine, if we see, we had to go nearly 7 to 8 centimeters depth inside the spine to reach the spinal canal. And we had to go through several layers of tissues, right from the skin, the fascia, the ligaments, the paraspinal muscles, the bone, and this was particularly very difficult in obese patients. Now, if you go through the literature, most studies would show you that after decompression, patients had excellent decreased leg pain, nearly 70% success rate with these decompressive surgeries. But sooner or later, they all complained of back pain, and this percentage was very high. Nearly 50% of population which underwent open surgeries had some sort of back pain or chronic ailment in the back. Now, this was due to the collateral damage of our surgery, of our approach. So, this is the schematic diagram of the traditional spine surgery where we used to elevate the muscles from the spinous process. We used to use broad retractors, cut the spinous process with double action bone cutters and big instruments. And then we used to remove the complete flavum to gain access to the spinal canal. Now, what is the final goal in all these kinds of procedures? It is decompression of the nerve. Now, this decompression has to be very safe and it has to be definite. So, any collateral damage which was caused due to the invasiveness of our approach, that is what increased the post-operative morbidity in all these procedures. So, the decreased scar tissue means more success rate and more better surgery. Now, these are the two pictures. These are my own patients. Left hand side was the conventional spine surgery when I just finished my surgical training and started doing conventional spine surgery. These were the extensive scars for the patients. And now what we do with endoscopy, the scar is literally 7 millimeters. And many a times we can close it without without it with a stitch. We can just put a waterproof dressing and send the patients home. So let's come to brief history. So initially, the microscope was introduced by Professor Yasser Gill in 1977 in spine surgery, and that reduced the exposures. Then various devices were put into spine surgery, like the Casper retractor, the macular retractor. And what were the lessons learned during this? That microsurgery decreases the collateral damage. But yes, it required discipline, it required preoperative planning. So we had to, first of all, define which level to operate. We had to put a marker on it. We had to take a preoperative X-ray so that we don't do a wrong level surgery. Then we had to decide on access strategy, that what is exactly our pathology, whether I would do an interlaminar approach, whether I would go for an paraspinal approach, how extensive would be my approach. And then we understood the importance of respecting the anatomical pathway. Now, during the evolution of these spinal procedures, there were different systems that were evolving. One was the tube systems, one was mini speculums. These were developed to reach the spinal canal. And essentially, three approaches were explored: the interlaminar approach, the translaminar approach, and the foraminal approach. At the same time, endoscopic techniques were also being developed, and a method of percutaneous nuclear extraction, the posterolateral approach, was evolved in 1975 by Dr. Hijikata in Japan. Later on, Dr. Parvez Kamin defined the safe route for discography, that is the safe triangle of Kamin, that is the foraminal area between the two routes, that is the exiting and the traversing routes. Building on this approach, Dr. Anthony Young described his YES system, and transforaminal approach was regularly started being used since 1995. Essentially, it was an inside-out technique where endoscopes were put inside the disc, and through the disc, we tried to remove the herniated fragments. At the same time, endoscopic interlaminar techniques were also being developed, and Dr. Sebastian Rutten from Germany published a new alternative to central pathologies and paramedian pathologies through the interlaminar route. Now let us see what actually the definition of these terms mean. So MIS, that is the minimally invasive surgery. What is the definition? It is doing only what is necessary and dealing with the pathology without disturbing the normal anatomy and physiology. That's the definition. What is minimal access surgery? It is accessing the pathology with minimal destruction of the intermediate normal tissues. Similarly, what is the term natural orifice surgery? It is utilizing the natural orifices and windows in the body to access the pathology. Now, these are the three representative diagrams of the three approaches. The left-hand side quadrilateral diagram is of the open disc decompression or microlumbar decompression, where the skin incision was large and there was a lot of stripping of soft tissues so that we could gain sight, we could see in the depth in the spinal canal. Later on, to overcome this, MED type of surgeries were developed where the skin incision was small, but inside near the spinal canal, there was extensive soft tissue retraction and it was like a tent. But true endoscopic surgeries are the least invasive surgeries, and they practically satisfy all these definitions, particularly transforaminal endoscopy. We do it through the natural orifice, that is the intervertebral foramen. It is a minimal access surgery because there is minimal or no destruction of intermediate muscular layer. we dilate those muscles and gain access to the disc. And as we remove the endoscope out, there is no dead space created. All the muscles, they are put back and the entire tract seals off. So in true sense, monoportal endoscopic spine procedures satisfy all these definitions, and they are really minimally invasive. Now, I would like to bring your attention to some newer concepts in lumbar canal stenosis. Now, if you see the dissection diagram here on the left-hand side, this is the ventral dissection. What we are seeing is actually the ligamentum flavum between the two laminar segments from ventral aspect. And this area marked as X is lateral extension of that ligament flavum in the intervertebral foramen between the two pedicles. So it looks like a bat, wing of the bat. And now this is the tissue which actually is the main culprit in causing lumbar canal stenosis or the stenosis symptoms. Now, lower down here is the MRI picture. Now, to see this particular lateral extension, we have to do a certain different types of MRI cuts. We can call them as SI joint protocol. So if you instruct your radiologist to do the SI joint protocol or coronal sagittal cuts for the MRI, you can see this lateral extension of ligament flavum going between the two pedicles and compressing the exiting root. So symptomatic stenosis in foraminal and subarticular zones is the main culprit, and this is caused by this F denoted in this diagram. This is the lateral extension of the flavum, which compromises this space. Now, this is a paper by Lee and his colleagues. So this is a practical MRI grading system for lumbar foraminal stenosis. Now, I would like to bring your attention to this large enlarged diagram on the right-hand side, where you can see that the exiting root is being compressed from all four sides. Now, the side above and medial is the vertebral body, and this is the pedicle. Now, these two sides are bony, so these cannot be extended, whereas ventrally and inferiorly, this is the disc and this is the lateral extension of ligamentum flavum. Now, both these sides are soft and we can make changes in them to release this exiting root. Now, if you see the patients of stenosis, they usually complain of claudication and radicular symptoms, but these symptoms can be unilateral or bilateral. Now, bilateral claudication can be due to bilateral foraminal stenosis and not always central stenosis. So anytime when a patient walks into your clinic with the symptoms of claudication, particularly symptoms of tingling sensation, numbness in the legs, heaviness in the legs, with reduced distance of walking or reduced duration of standing, these symptoms can be caused either by bilateral foraminal stenosis or central stenosis. Now, in case of bilateral stenosis, we need to ask the patient, does the symptom start on the same day? And on more investigative history taking, the patient would tell you that commonly it has started differentially. It means the radicular symptoms in one leg has started before the other, and it very rarely starts in both the legs at the same time. Now, radicular pain and symptoms are due to compromise of dorsal root ganglion and not due to the pathology or the flavum which has solidified or which has increased in size and compressing posterior to the dural sac. And commonly, if you see, the symptoms which are seen are at the L4, L5 level or L5S1 level. And most often, the L4, L5 dorsal root ganglion is just sitting inside the foramen and it is very easily compromised. Now, with advancing age, what happens is there is change no change in the dimensions of the bony boundaries of the foramen after skeletal maturity. So once a person matures skeletally, the bony boundaries, they do not enlarge. But what changes is the disc height. It reduces due to collapse and herniation. And with this collapse, as the disc subsides, the superior articular process tip high rides into superior foramen. Then the tissues around the tip of the superior articular process, that is the lateral extension of the flavum, they hypertrophy and they make the area more narrow and hard and unyielding. So these are the two anatomical cut sections of a normal foramen, where you can see that there is a root sitting in the top of the teardrop, that is in the top of the foramen. There is good fatty sign around and the tissues are well seen. And whereas in the lower section, you can see that there is complete degeneration, subsidence of the disc, and now the root is compromised in the upper part of the foramen because there is high riding of the superior articular process, and there is some hard tissue, inspissated tissue around the tip of the superior articular process, which is actually the flavum and the capsular tissue here. Now, another thing which we need to understand is this exiting root is held very tightly in position with foraminal ligaments, and these ligaments do not allow it to move. Now, with foraminal compromise, there is increased vascular congestion. The venous circulation of this root gets compromised and there is swelling, and literally there forms an internal compartment syndrome. So now this root swells in already compressed area in the already compromised foramen, and this causes vascular congestion and claudication symptoms. Now, foraminal decompression and detachment of lateral border of ligamentum flavum is very difficult from the posterior interlaminar approach, because access to the lateral attachment of ligament flavum at lower lumbar levels requires more resection of lamina and a bone of pars in the traditional approach. Now, this can create a significant instability, and that is why fusion surgeries were invented. So actually, it is the iatrogenic damage which we caused, and now we want to stabilize it with screws, rods, and metal, and the cage has to be put in between the two vertebral bodies. But can we come across these problems with some other approach? Yes, it can be approached very easily by transforaminal route. Endoscopic approach around the superior articular process is very easy. Removal of the lateral spread of ligament flavum and the junctional tissues gives excellent relief to patients. Now, you consider this landmark line, which is passing through the inferior end plate of the upper vertebra, and it just touches the tip of the superior articular process in a normal foramen. But where there is a collapse and degeneration, the superior articular tip will be cranial to this line. Now, if you examine your sagittal sections of your MRI or a CT scan, the parasagittal sections on left and right side, wherever there is foraminal compromise, you will observe this phenomena, and this will give you a rough idea of how much decompression needs to be done. I would like to bring to your notice this very phenomenal and important paper by Saeed Usman and his colleagues, where they concluded that transforaminal decompression produces a significantly larger increase in the intervertebral foraminal area than posterior decompression, and without increasing the range of motion of neutral zone in any direction. So endoscopic transforaminal decompression is a very feasible alternative as respect to the current approaches. Now, this is a schematic diagram of the endoscopic view. So we actually land just underneath the facet joint between the two roots in the Cambine's triangle. We identify the roots, and then we start drilling the tip of the superior articular process to reach that lateral spread of ligament flavum and do the decompression. Now, for these approaches, these monoportal foraminal decompressions, the equipment required is very simple and not extensive. Only 4 or 5 instruments are required. That is a hook, an endoscopic curette, a punch, a burr, and an upbiting forceps. Now I would show you a small video. Now see, this is the dural tube. And whenever there is stenosis, the pathology, it can be in the foramen, it can come from the lateral side. Try to imagine this canal into 360 degrees as a tube. And the pathology can be ventral, pathology can be dorsal, or pathology can be on the lateral aspect of this canal. Now here in this MRI, if you see, the pathology is on the ventral side. There is a hard herniated fragment on the which has migrated inferiorly just underneath the dural tube, as well as there is lateral extension of flavum which is causing lateral canal stenosis. Let's see the axial MRI. Here you can see that the left-sided exiting root is free, and nicely we can see the dorsal root ganglion. Whereas on the right side, on the left side, what we can see is the down migrated fragment here, and there is compromise in the foramen and the lateral recess, which is compressing the entire exiting root as well as the traversing root, giving rise to unilateral left-sided symptoms in this 78-year-old gentleman. So we land our endoscope just underneath the facet, and we start drilling or burring the tip of the superior articular process. As we burr the bone, we come across the lateral edge of the flavum. So slowly we tease that flavum away from the dural tube, and we use the endoscopic Kerrison forceps, and slowly under vision we remove piecemeal all that hardened flavum. Now this is the end plate and this is the dural tube. Now we are trying to reach the down migrated fragment, and we can very well get out those hard annular fragments which have migrated between the dural tube and the vertebral body. So once you do it, you can see that the complete lateral recess is decompressed, and also the axilla and exiting root is decompressed. Mind you, these surgeries can be done under local anesthesia. So even with a gentleman who is 78-year-old having multiple comorbidities, these procedures can be very easily done. Another case where you can see this is the tip of the superior articular process, the area around it, and now there is lateral recess stenosis. Another pathology which is ventral to the dural sac, that is an end plate osteophyte which is also pressing in the lateral recess, causing the stenosis symptoms. So similarly, we land just in the foramen underneath the superior articular process or the facet joint, and then we start burring. Once the tip or just 3 millimeters of bone is burred out, we come across the lateral edge of the flavum. Once that flavum is removed, now we can see that this is the osteophyte coming from the end plate. So very easily with slow tapping, we can morselize that osteophyte with an endoscopic chisel. And we break that bone so that we can remove it piecemeal through our central channel of endoscope. We do not need to enlarge our incision or increase our invasiveness. So piecemeal, we can remove that bone. Once we do that, we remove all the soft tissues around it. And voila, this is the dural tube completely free. This is the bare bone from where the osteophyte was removed. This is the axilla of the exiting root. And this is the dorsal root ganglion and the exiting root, which is free now. So we have decompressed the foramen, we have decompressed the lateral recess, we have decompressed the two roots. This is the immediate follow-up MRI, where you can see recreation of the foramen, and now the root is completely free. This is the pre-operative and post-operative MRI showing good decompression. This is the axial MRI where you can see that the lower osteophyte is gone. Now, one has to be very careful. You need to understand the articular placement. The radicular artery just passes cranial and ventral to the root. So you need to be very careful while operating in this area. Otherwise, there can be bleeding, which can obscure your sight, and you may have to abandon this procedure. Another process, another video. So here you can see there is foraminal stenosis. Again, this patient had unilateral symptoms. So this is we land just underneath the facet, start burying the bone. Once you have removed the bone, you come across the lateral extension of the flavum. Use your endoscopic keresons under vision, remove all that soft tissue. You can also use radio frequency probes. This is an up-biting forceps being used. And this is not time consuming. The entire procedure can be done in maybe 45 to 50 minutes time. So once you shrink all that junctional soft tissue, this is the exiting nerve in view now. This is the tissue in the axilla of the exiting root. And this is the dural tube and the lateral recess, the traversing nerve just passing here. So now you can see that you have freed both the nerves, and this is the pre and post-operative MRI showing good decompression in the lateral recess as well as the foramen. And I have extensive follow-up of all these patients, and they are still very happy even after few years. So this lady went home next morning and came walking completely pain-free for a follow-up after a week. Now, complications. Yes, no procedure can be devoid of complications. Dysesthesia is a very common complication because you are working around the dorsal root ganglion, but usually it is short-lived and we can control it well with analgesia. Dural injury is also a possibility, bleeding, and of course discitis if you don't take proper precaution because the approach is through the disc, so discitis may occur. Now, friends, any pathology which is in this corridor, we can very well reach through the transforaminal approach. But this includes the foraminal stenosis, a little extension of the flavum, lateral recess stenosis, and all disc herniations or any pathology that is ventral to the dural sac. But there are some pathologies sometimes which are dorsal to the dural tube, and these we cannot reach through the transforaminal approach. And for that matter, we can use monoportal interlaminar approach to reach these pathologies. Particularly, this is the recent case done few days back. You can see there is tight stenosis with ligamentum flavum hypertrophy bilaterally with complete stenosis of the thecal sac. So people ask me why deviation from transforaminal route of endoscopy. So in case of central stenosis with flavum hypertrophy or a multi-level pathology, multipathology, transforaminal route has limitations and it has to be done from both sides and multiple levels. There is time restrictions, particularly in old patients, and sometimes there is not enough central decompression. So what is the best way to deal with combined central and lateral recess stenosis? Then that is monoportal interlaminar route. Now, by traditional decompression surgery, laminectomy, we cut the bony scaffold of the spinal canal. Whereas MIS approach, what we explore is the fat atrophy. So this is the MRI which shows that in the midline, there is a fat atrophy, these white signs. So we explore this area and go in the interlaminar window. Now, particularly, you need to consider certain things of anatomic importance. That is the size of lamina and angle of facet joint while you plan your approach through the interlaminar route. And as we all know, from L5-S1 to L3-L4, as we go higher, the laminar size decreases and facet becomes more vertical in these patients. Now, this is a general algorithm which I use in my practice. Whenever there is a multiple combined lesion with a herniated nucleus pulposus and severe central stenosis plus lateral stenosis, I would do a monoportal interlaminar approach, that is percutaneous stenosis lumbar decompression, or PSLD. Whenever a patient has an herniated nucleus pulposus with foraminal stenosis, I would definitely use transforaminal endoscopy. And again, when there is a combined lesion like central, lateral, and foraminal stenosis, I would consider doing a PSLD rather than just a transforaminal endoscopy. Now, what are the advantages? Definitely, it is less damaging, no muscle stripping, the interlaminar ligaments, the interspinal ligaments remain intact. We use the fat atrophy for this approach. It gives excellent visualization, and these surgeries are done under irrigation. So we have excellent field of vision and excellent hemostasis. What are the advantages over UB? No triangulation is required. So even the beginners, it is very easy to learn and start these procedures. Definitely, it is less damaging as compared to UB because there is less stripping of soft tissues and there is less muscle edema as compared to UB in monoportal techniques. Now, these are the requirements. You require a specialized endoscope with a central channel of minimum 5.7 to 5.5 millimeters, with a lens angle from 0 degrees to 15 degrees to 25 degrees. Certain access instruments are required. And then, yes, the Kerrison bone punches, root retractors, burrs, chisel, radio frequency probes, and fluid pump. I particularly do not use any fluid pump. I use simple gravity irrigation, which is more safe and it gives me a very clear vision. So in general, this is how we position the patient as you do for your routine spine surgeries or bolsters or a Wilson frame, so that to open up the interlaminar spaces. So here in this case, I've done it under epidural analgesia and sedation, but you can do it under GA as well. So this is how we do the skin marking. We mark the midline, we mark the upper end plate, we mark the upper lamina, the edge of the upper lamina, and then we mark our approach just close to the spinolaminar junction. We just take a skin incision, stab incision through the skin and the fascia, and the muscles are dissected bluntly with a dilator. No stripping is done. Rest of the procedure is very common as what we do in conventional open surgeries, that is a laminotomy, burring of the facet, flavectomy. Then we identify the lateral edge of the traversing root, retract the dural sac, do any disc decompression if needed, and simultaneously we can tilt the endoscope and do the contralateral decompression just as we do over-the-top decompressions in MED or other types of surgeries. So these are some general steps videos. So this is how we explore the fat atrophy. So first, when we put the endoscope, we come across this golden soapy tissue, that is the fatty tissue. We remove that. Next step is radio frequency clearance of that soft tissue. So here I'm using a 4.1 megahertz radio frequency probe to just coagulate and shrink that soft tissue. And actually I'm touching the bone down there. So I can palpate and see the free edge of the lamina above. So once you do that, you identify the bone. If there is enough space, you can use your Kerrison rounders to do a limited laminotomy. So this is how you start doing the laminotomy. Then you can also use a high-speed burr. This is a diamond burr being used to selectively do a laminotomy. Just enlarge the window. You do not cut the bone around the pars, or you do not destabilize the segment by cutting the entire facet. You just want to reach up to the free superior edge of the ligament flavum. So you can appreciate the clear vision due to the surgery being done under irrigation. Next, as we come across the free edge of the flavum, we try to separate the two layers, superficial and the deep layer. In case of tight stenosis, sometimes the flavum is adherent. There is some calcinosis, so you need to probe it with a blunt probe, release it, and then you can do a flavectomy. Once you do that, this is the ipsilateral decompression. You need to reach the lateral edge of the dural sac, and only then you can start retracting the dural sac to look on the ventral side. So you do not require to cut any further facet. So this is the area where you can usually find your herniations. So this is the lateral recess decompression being done. Similarly, you can just tilt the endoscope on the contralateral side and you can do the contralateral decompression. And by moving the endoscope, you can actually see on the contralateral side, you can see the root and the vision is extremely clear. We are trying to approach the disc fragment. You can use a endoscopic root retractor like this, and you can put your radiofrequency probes or other instruments through this. So it is absolutely safe. So without injuring the dural tube or the roots, you can do the decompressions. So here a probe is being used to remove the migrated disc fragments. Yes, again, there can be some complications like bleeding. There can be neck pain due to high irrigation pressure. There can be dural tears. There can be root injuries, discitis, and there can be instability if you do excess bone cutting. You should be aware of all these complications, and in your training, you need to take them in consideration. So this was just a basic introductory talk for you, just to show that how monoportal techniques can be used for decompression of stenosis. And this is a targeted approach depending on wherever the pathology is, whether it is ventral to the dural sac, whether it is dorsal to the dural sac, whether it is in the foramen, whether it is in the lateral recess. And accordingly, you can plan your approach. Accordingly, you can plan your endoscopy so that it becomes truly minimally invasive and it gives excellent results to you and your patients. So with that, I would conclude my talk and thank you very much. And now let us take any questions or queries if you have. Thank you so much.
Thanks for your detailed presentation, Professor. You have shown excellent examples. It was like an endoscopic spine festival. You can stop screen sharing.
Yeah, I will stop the screen sharing.
See, yes, each other. All my questions were answered during the presentation. I will direct the questions to you from participants from chat part. Professor Dr. Yunus Aydın said that I'm agree with you concerning minimal invasive surgery for neural structures. You are comparing endoscopy with conventional surgery, but there's also alternative treatment with unilateral approach, bilateral decompression with the microscope. If you use his mini refractor influenced by Taylor macro refractor. Thanks to this mini refractor, 10 millimeter width, I can do real minimal invasive surgeries and the patients can send home less than 24 hours. His cohort is more than 4,000 cases in last 3 years. Comment.
Yes, so I completely agree with Professor Yunus, and what he says is completely correct. I myself, as a spine surgeon, I have matured through these retractors and these unilateral approaches, and we are actually evolving. We are building one step ahead on the previous types of surgeries. So yes, in good hands and with good training and with expert skills like Dr. Yunus, the results are equally good or maybe better or maybe amazing with the conventional techniques using a microscope. But as we are evolving, as the technology is evolving, now these surgeries are done under irrigation, where in a microscope we cannot do the irrigation surgery. Secondly, the depth perception in a microscope is different than a telescope, because in a telescope, the lens we can put very near to the pathology. And this is where there are some great advantages. Yes, if you consider the time, I would still say that even in my hands, if I do conventional microsurgery, it requires less time as compared to endoscopy, because we all are evolving, we are learning these techniques. So this comparison is not for bad. This comparison is for building our techniques, building our practice, and evolving ourselves. Sooner or later, our patients are going to demand that I do not want a open microsurgery. Are you doing endoscopic spine surgery? And then that is the reason, that is one of the reasons we need to learn these newer techniques and be more skillful. So that is my comment. So I fully agree with Dr. Yunus, and well, that is my comment on it.
Thank you, Professor. And Professor Hasan Kamuscu, thank you, Dr. Kavi, for your excellent lecture. There's a question. You use high-speed drill for drilling the superior articular process. Can hand drills 5, 6, 7 millimeters diameter be used for this purpose?
No, the drill which I just now used for the transforaminal approach is not a high-speed burr. It is actually a low-speed burr. It is a simple steel burr of 3.5 millimeters diameter head of steel. So it can be attached to any orthopedic or neurosurgery drill, and it can be used under low speeds. But to answer your question, yes, hand drills can be used of 5, 6, and 7 millimeters diameter. But these 5, 6, 7 millimeter diameter drills will not pass through your endoscope. And then it would be a blind drilling, as we used to do in direct outside approach, which was propagated by great Dr. Thomas Hoagland, where we used to do a foraminoplasty, blind foraminoplasty. But then that is a little unsafe as of today, because we need to see what we are doing. We need to see where our instrument is landing. And for that reason, you should use a burr which can pass through your endoscope. So usually 3.5 millimeters to 4 millimeter diameter drill or burrs can be very easily used. And there are multiple companies manufacturing various of these drills, which are low speed. You do not require a very high speed burr, particularly for a transforaminal approach. For interlaminar approach, in a very tight stenosis where the bone has become sclerotic, in these cases, yes, you would require a high speed burr, and there I would prefer a diamond burr so that it creates less bleeding. So yes, you can use 5, 6, 7 millimeters diameter burrs, but you should avoid using them, because then that becomes a blind technique.
Thank you, Professor. Is another two questions from Hasan Kamuscu. One of them, we have difficulty for taking out interpedicular ligamentum flavum. It escapes from mouth of the endoscopic carcinoma arranger. Is there any tip to remove this lateral ligamentum flavum?
Yes, friend. First of all, I would congratulate you that you have this question. It means that you are trying to do the foraminal decompression with endoscopy. And yes, in the beginning, I also had this problem of getting that flavum, particularly going through a paraspinal far lateral approach. So you need to have a better Kerrison forceps of 3.5 millimeters size with really very thin footplate and a wide opening. Other way to get around this problem is to use a upbiting forceps, which I had shown in my video. Those forceps are also available with multiple manufacturers, and they also help you to catch that flavum, which is not easily to be caught in uh, regular Kerrison forceps. So you can use an upbiting forceps for that.
And last question from Professor Suju. Is the length of the scope you use in interlaminar endoscopic surgery different from the scope you use in translaminar surgery? Or is it the same?
So to answer that question, yes, the same scope can be used for transforaminal as well as interlaminar decompressions. But as we all are aware that in case of interlaminar approach, we need to do more of bone work. And for that, we require more sturdy instruments. So bigger Kerrison forceps, bigger burrs are utilized. And for that matter, a bigger diameter endoscope is used in case of interlaminar approach. And we prefer that these scopes are of smaller length. They are shorter as compared to transforaminal approach because then it becomes easy to maneuver your instruments inside and out the endoscope. So yes, you can use the same scope for both the approaches, but it is better to have different scopes.
Thank you, Professor. Dr. Duran Berker Cemil, thanks your wonderful presentation. Dr. Bahavattin Komikoev, thanks for interesting presentation. Dr. Nurullah Kösmene from İzmir. Thank you, Professor. It was a great informative lecture. And as far as I can see, there isn't any question or comments in the chat part. Thanks again, Professor Kavi.
Yeah.
I return to Professor Kamil Sucu for the closing speech.
Yeah, Dr. Selin, before we conclude, I would like to tell all my friends from Turkey that I have visited Turkey several times for attending minimally invasive spine conferences, and I have come across great Turkish surgeons. One of them is, I know he's sitting in front of me, Dr. Hassan, and they all are doing all these types of approaches, these great endoscopies. So this is not whatever I showed you today is nothing new. It is being already practiced in your country. So I just wanted to re-emphasize, and this talk was a basic talk, particularly for our young generation, our residents who are just entering into the spine surgery. So they should definitely take up these types of surgeries, and so that they evolve and they become better and better with day and day. So that's the comment I wanted to make. Thank you so much for giving me this opportunity. And now, yes, please, let's listen to Dr. Hassan.
There is one more comment
Yes.
from
And Dr. Edwin must be from Bulgaria. I would like to thank you for the great lecture. I learned some new things for which I am grateful.
Thank you so much, Dr. Edwin.
Thank you, Dr. Anand Kavi. It was extremely useful for me, especially. But probably we need to see you on your hospital to see if you accept us. Yeah.
You are most welcome, sir. It would be an honor to me. And as I've already said, that I have a long list of Turkish surgeon friends, and you are all are always welcome. And please do come. We can not just have good learning, but we can have a good time together.
Thank
So
you.
you're most welcome.
Probably we will see each other in Mumbai.
Yes, sure.
Yeah.
Looking forward to it.
Thank you.
Okay, thank you so much.
I will
Bye-bye.
thank everyone who joined us today, this evening. Thank you. Bye-bye.
Okay, bye-bye.